takeaway. Welcome back to the channel. Today we are going to talk about a new entity called MOGUE. Just to put it in context, as you know, surgery is already an option for the treatment of certain cases of epilepsy, refractory cases, especially when we find correlation among clinical findings, electrophysiological studies, and imaging. The specimens obtained from these surgeries, sometimes between 2 to 26% of cases, are considered by the pathologist non-lesional. Some of them do have alterations, but they don't fit any established diagnosis. Just to remind you, the Eli classification of 2011 describes 3 types of focal cortical dysplasias: type 1, A, B, and C, type 2, A and B, and type 3, A, B, C, and D. Okay, MOGUE seems to represent an important portion of these cases, and moreover, many of these cases do not do well with surgery. Okay, MOGUE stands for mild malformation of cortical development with oligodendroglial hyperplasia and epilepsy. The history of this entity is not that long. In 2002, Berger described the presence of high density of oligodendroglial cells in the subcortical white matter of certain specimens from surgical cases of epilepsy. Years later, in 2009, Hamilton and Nesbitt again found the same alterations and correlated them with MR abnormalities in one patient, increase of the cortex thickness and blurring of the gray-white matter interface. Then in 2013, for the first time, Chorus named this entity as POGI. POGI stands for proliferative oligodendroglial hyperplasia with epilepsy. Then in 2016, Sture again renamed this entity as MOGUE because they found heterotopic neurons in the subcortical white matter, so they considered it as a member of the spectrum of the cortical malformations. And finally, in 2018, Hartlieb defined 2 subtypes of MOGUE according to their MRI appearance. Well, and what are the histopathological features of this entity? Well, you can see here a cartoon showing the cortical white matter interface. The neurons are in red and the oligodendrocytes in green. As you can see, there is an increased density of oligodendrocytes in the juxtacortical white matter, but not just there. There is the same increased density of these cells in the deep layers of the cortex. The neurons are heterotopic and are in the juxtacortical white matter, but not beyond 500 nanometers from the junction. The oligodendrocytes have an increased mitotic activity that tends to lower with time. On the other hand, what's very important is what we do not find in MOGUE. There is no dyslamination, neither horizontal nor vertical, and this differentiates MOGUE from focal cortical dysplasia type 1. There is no balloon cells or dysmorphic neurons, and this differentiates MOGUE from focal cortical dysplasia type 2. The heterotopic neurons are not found in the deep layers, in the deep portion of the white matter. There is no clustering of oligodendrocytes around the vessels, which is a very common finding in temporal lobe epilepsy specimens. And there is no sign of tumors. There is no tumor infiltration, the IDH mutation is absent, and there is no 1p19q co-deletion. Well, and what is the pattern on imaging? MOGUE affects predominantly the frontal lobes, Nevertheless, there are some reports about the temporal lobe compromise as well. The distribution is usually multifocal and patchy, and on T2 and FLAIR you can see hyperintensities at the juxtacortical white matter and blurring of the gray white matter junction. Well, as we said before, Hartlieb et al. In 2019 proposed a subclassification of MOGUE in two subtypes. Subtype 1, which occurs around the age of 2 to 3 years and is characterized by hyperintensities at the juxtacortical white matter, and these hyperintensities are usually lineal. And type 2, which happens around the age of 14 years, and the conversion between them occurs around the age of 3 to 5 years. The reason of this change is not clear, but they mentioned the high proportion of precursors, oligodendroglial precursor cells in the subtype 1 form, and maybe the myelination, the maturation of these cells is the reason of this pattern change on images. Well, before finishing this video, I would like to mention a very important caveat that we have to bear in mind if we want not to misdiagnose MOGUE. There are normal linear hyperintensities at the subcortical level in the frontal and temporal lobes up to the age of 3 years. This was nicely shown by Cecilia Parazzini in her paper published in 2002 in HANR, where she showed that these areas may be present up to the age of 3 years, and they tend to disappear in a dorsoventral pattern. Finally, we welcome MOGUE to the spectrum of the etiologies of refractory epilepsy, and there are several questions that remain to be answered. One is, what is the etiology of this entity? There are two theories. One is the maldevelopmental one, that stands that maybe MOGUE is a mild form of a migrational disorder, given the finding of heterotopic neurons at this level. And the other stance or proposes that maybe MOGUE is a secondary regenerative phenomenon, and this is very interesting. On the other hand, we don't know why MOGUE produces epilepsy, given that glial cells do not have action potentials. So the proposal is that these aggregates of oligodendrocytes in some way lower the threshold of the nearby neuronal networks for seizures. And another important challenging concept is that maybe we need to perform more extended resections of these lesions, given that the outcome was not good for the patients that are published. So the reason is probably that these lesions are multifocal. So with this, I would like to thank you for your attention and invite you to subscribe to the channel. Bye bye.